They are so keen to be a place that allows for connectivity. They have many different types of culture than what we have here. Many of the Eastern European countries have less of concern, shall we say, around government's involvement in personal data. So that facilitates a whole lot of what you've seen here. In the Canadian context, because of our 19th century constitutional structure, we are severely limited in our ability to integrate. And what I've seen in the past number of years being involved across Canada, is a siloization and a retrenchment to the silos of the provinces. So each province trying to do its own thing. And the challenge with that is you have some provinces like Ontario and Quebec, very big capacity, BC, and then you have small provinces, Nova Scotia, PEI, et cetera. And so how do you get all of that working? To me, I think speaks to a failure of leadership in this country to really see the future and enable that future. There are lots of challenges around this future scenario, not the least of which are the implications of AI. And AI is the back door of all of this. Automating Inequality, an excellent book by Virginia Eubanks, details that, primarily US data, but the embedment of bias is a real concern. And I'll stop by saying that healthcare is the most highly regulated industry for good reason. And so many of these things require, I believe, a national legislative foundation to enable but also to regulate. And I think that's the conversation that's missing in Canada.
It also requires modernization, though. And I don't want to put cold water on this because it's a great video, but we're still using fax machines in Nova Scotia to communicate health information from office to office. So this feels like a reach. And it's, so, if the question is, are we ready? What do we need to do to get ready? Do we have a tolerance for disruption? I mean, this future is at the fingertips of the banking industry, the tourism industry, Walmart, everybody else but us. So, what makes healthcare special sometimes is our inability to get unstuck from the status quo and actually work really fiercely hard to defend it, even when it's not meeting the expectations of current day. But, Gaynor, I guess if a question reaches even beyond that to talk about the kinds of collaborations that we need and to think of how we translate this kind of futuristic data picture into an even broader discussion about what the future of health is, where would you land in that conversation?
Oh boy. So I'm willing to bet that you didn't invite a public health physician to a panel like this to talk about a technology-based approach to population health, which is what I practice. Because what I would say is that the future that I imagine actually doesn't need as much of this actually as we think. The future that I imagine actually is a future in which we have eliminated the risk factors for the diseases that are causing illness to begin with. And by the way, if you think that's the holy grail, I can assure you that we have lots of examples from around the world where in fact public health has been able to exactly that. But locally, just think tobacco as a risk factor that largely does not exist for many generations of Nova Scotians now. And we don't need a big technological footprint to achieve that state. So my 2040 looks very different than this. And so I have a bit of a question around what problem is it that we're trying to solve by applying technology to it. The footprint of our healthcare system right now is grossly overinflated. I think we can all agree on that. And in many provinces and territories right now approaches 50% of provincial budget spending. But we have a Senate report in Canada from 2009 that states bluntly, as the first line of their summary on the page of the Senate of Canada, the webpage for the Senate of Canada, that only 25% of a person's health outcome is contributed to by investment in health systems. So if this 2040 future represents more investment in health systems, I'm not sure that it's going to meet the goal. There's 75% of other stuff that is education, income, transportation systems, social security systems that requires more investment. If the goal of this, sort of revolution and disruption is to appropriately shrink the footprint that is grossly overinflated now, then I think that's a conversation we're pursuing. But I guess that's the question I would ask my fellow panelists: is what problem are we trying to solve? When you talk about prevention, Paula, I guess I see there's some prevention potential, but it's at a, what I would call a primary and secondary prevention state, meaning that we're preventing risk factors that already exist from becoming disease, but what about preventing the risk factors from existing in the first place? How much of this actually can reasonably be applied to that?
Right. So maybe I'll speak to that. I agree 100% with what you're saying, and one of the things we had said that we might talk about was what are the obstacles to doing things differently, and I think one of the obstacles that is often put out there is fiscal constraint. I see fiscal constraints in Atlantic Canada as an enabler rather than an obstacle. And I'll give you an example where I see that coming to play. Newfoundland. So we're all aware, Newfoundland and Labrador fiscal situation is dire, facing all the same pressures here with demands, aging population, all of the things, expectations of consumers and the like. So they have said, how do we survive given there is no more money? So what they've done, they have gone to the private sector to look for innovation partners, and they're saying the only way we're going to survive is innovation. They are an integrated health authority, so they go from the community through to long-term care and rehab. And they're very interested. Everything they're doing is about the social determinants of health. And so they've said to the innovation partners, we will be a living lab. So we will give you access to our data, to our clinicians, to our decision makers. And we want you to come in with ideas to solve our problems. So we are working in partnership, and so Deloitte is one of 10 innovation partners. They've also demanded that as an innovation partner, we work with the local health ecosystem, startups, because they know that a healthy economy is a contributor to a healthy society. So it's remarkable what they're doing. And one of the projects that we're just about to start is something we call a smart health community. And we've identified seniors in rural Newfoundland as a major issue facing Eastern health. So what we're looking at is, it is some technology enablement, but there's so much more than that. So imagine seniors would become part of a network. So they might be referred by their GP, they could self-refer, the son or daughter could say, Mom or Dad, I'd like you to be part of this. So just using your smartphone, you put in a personal profile and you say, I love to read, I love to do yoga, I hate cycling, I love to travel, and you identify what your life goals and your health goals are. And you're connected with this network and information about, there's yoga in the community, there's a lecture on something that's of interest is pushed out to you. We're building gamification in, because some people do like to be rewarded, they like to get points. And with so many points, you get a discount on healthy food at the local Foodland. So it's connecting people, but to supports, not health, way, way beyond how we would traditionally define the health system. But the costs in 2019 are peanuts. This is not hundreds of millions of dollars. This is thousands of dollars to bring people together in a network, to nudge them to make better choices. So I think it's a different world, and I don't think we need to spend hundreds of millions, billions of dollars nationally to do some of these things.
Go ahead.
Oh, I got more. Okay. And thank you, Paula, for that. And by the way, Paula, I love you. Thank you. Because here's where I go with that, and I've had the same conversation with Eastern Health, actually, at the time that they were bringing in these consulting firms, IT firms, to have this conversation about population health enabled by technology. Because I would agree with you that there is definitely some value in creating that connectivity within a network of citizens to be able to sort of take advantage of opportunities that are there. But from a population health perspective, where I start to worry, where my colleagues start to worry, is what if the opportunities actually are not there because they have not yet been built? That's where I see the limits of the technological approach, and I also see the real urgency in terms of what's coming at us from a health system and health conditions perspective to pay attention to. So I regularly say to my colleagues, my acute care colleagues, my physician colleagues who sort of look at what I do as a public health physician, and they say, what exactly is that about? And I go, okay, so every single one of us knows what to say to a patient to get them to be cardiovascularly healthy. Eat better, exercise more. And we can point them potentially to the resources in the community that might help them do that. Here's where you can buy the best food in the neighborhood, and here's where you can get coupons for healthy food and that type of thing. But actually, if it hasn't been zoned for in the city, for a grocery store to be there that is selling the fruits and vegetables that we are telling everybody they need 5 to 10 servings of a day, then it doesn't matter what we say in our acute care institutions. So there's a piece in which, I wonder if there's a frontier that we need to sort of broach, if it is using technology. I'm not sure that it is, which is how do we nudge policymakers and the holders of those institutional keys to actually create the conditions in communities that allow people to take advantage of them.
Agreed. I just don't want to say this is not a panacea and it's not one solution that solves all the problems. It is a solution that will work with a segment of the population.
Was there something you wanted to say?
No, go ahead.
Okay. I was just going to challenge two assumptions. And if we talk about 25-year-old Bibles of what a health system could look like, I think there are two assumptions that we really need to challenge. One assumption is that there is anything that actually exists called a healthcare system, because I don't believe there is one. And the second is this notion that we are cash strapped. In Nova Scotia, we spend $4 billion and change on sickness care. And when I started in this game 25 years ago, we hadn't quite topped the $1 billion mark. I'm not confident that we're getting 4 times the health care or that politicians are getting a quarter the grief. So there's a point at which we need to acknowledge that money is neither the problem nor the solution. But protecting what we are familiar with is the problem, and it's not the solution. Mm-hmm. Mm-hmm. So if we could liberate ourselves from that kind of fiscal boogeyman and say, within the pot that we're working with now, and apparently we can find more. We just signed another contract with physicians and there was more money. Magic, boom, somebody's printing it somewhere. So at what point do we reconcile what you're talking about, Gaynor, which is that the real gains to be made in improving health have nothing to do with the sickness care system? How do we reconcile the fact that we're stuck in the 1980s at best in our technology solutions, even from the point of view of straight up efficiency and protection of health information? We have some of the most archaic workflows in the health system that wastes people's time. I can give you evidence of how introducing a non-face-to-face encounter modality will save about a quarter of the time that health providers now need to devote in face-to-face care. So when are we brave in talking about what in no other sector would be disruption, but for healthcare is disruption, and we're not comfortable with that. We have no tolerance for that, and government is incapable of leading innovation because government, by definition, is supposed to keep things on the straight and narrow, keep it smooth, keep it quiet, don't keep it, that is what government does well. So who do we look to for the leadership that we're all saying that we need and we don't have? Peter, tell us.
I will in a minute. But I want to come back to Gaynor's.
I thought you wanted to say something. You were twitching there for a minute.
Because I completely agree with it. I'm a public health physician too. That's it. That's how I was trained. That's my background from Johns Hopkins. And I appreciated a long time ago that the 25% sickness industry doesn't really have a huge impact on health. But I would argue that I'm probably the only Deputy Minister of Health in this province, certainly, who has been arguing for economic development. Because economic development is about what Gaynor's getting at. But this brings me back to our conversation here, and I'll use a Deloitte reference. In 2020, the health and goods and services industry globally is a $10 trillion business. $10 trillion, so it's approaching $4.5 billion in Nova Scotia. But that's kind of artificial way to look at it. You really need to look at it as a percent of GDP. And a percent of GDP in Nova Scotia is pushing 17%. That's more like our big bad brothers and sisters in the United States, which we always point to. And so when we talk about what's the average spending across Canada at 10.5, that's nonsense. That's an average number. In Nova Scotia, our GDP expenditure on healthcare is 17%. That means that we're not getting to the economic development opportunities that we really need to be getting at, which is the economy of today and tomorrow. I'm sorry, but the economy is not about cutting down trees to make toilet paper. The economy is a digital economy, and that is a global economy. I'm about growing the economy in the province, and that means jobs, that means better lives for people, and all the tools that we use in the healthcare industry are tools in the healthcare industry. They are not the reason to do it. It is the economic development. It's the reason to do it. So let me come back to MJ's question, because I think it's fundamental. Governments confuse structure and strategy. Every 101 business school student knows that you have to have strategy before structure. Governments confuse the two. Strategy and structure is not going to change the outcome. People need to know, this is really the leadership question, where are we going in 5, 10 years? Are we going to the moon, or are we just going to Sheet Harbor? Because we need to know. We need to know. Because that people can put up with a lot if we're going somewhere where they can see it's worth going to. But if it's just the same old, and we're just changing the deck chairs, people start to get frustrated. And I think what you're seeing is a sort of a populist frustration with the status quo. People are hungry for leadership. And I've been around this province, and people want to know, where are we going? What does that future look like? They want to see that. Governments have an innate reluctance to put anything out there, because then they become accountable to deliver it. In a 4-year cycle, it's impossible. So that comes back again to the 19th century. I'm not talking 20th century here. I think you're too kind to say it's 1980s. Our fundamental structures are grounded in the 19th century. Both legislations around who gets to do what in this country on health care, and the structure of regulated professions. All of those fundamental pieces are the 19th century. And how are we going to deliver the changing world of the 21st century when our structures are grounded in old thinking? It's like trying to address the challenges pre-Gutenberg Bible in a post-Gutenberg Bible world. It's been said that we have 20 Gutenbergs headed our way in healthcare. 20 Gutenbergs. And what does that mean? That means that, let's just think about Gutenberg Bible, the printing press, the beginning of that. It was a major change. People argue, and I think it's true, that we're still dealing with the implications of the Gutenberg Bible, social transformation, industrial revolution. People could read for themselves. We're dealing with 20 of those coming our way, AI being just one of those. So the kind of leadership that we need is very different. The kind of leadership that says we are going to be a leader in delivering better health to the population, as in Gaynor's reference point. But that requires us to tackle some big things that may be very uncomfortable for a lot of people.
So we have a new CEO coming to NSHA. We have a new deputy minister coming from somewhere. What's our advice to them?
So maybe I'll start. I think one of the key issues we have today is lack of clarity around who's doing what, from the highest levels to the front line. I think, so who is responsible for strategy, Peter? Who is responsible for structure? I think in some cases, I would say no one. In some cases, I would say 2 or more bodies. So I think we need to be crystal clear on what is the role of the NSHA and the IWK, what is the role of the department, what is the role of the minister, what is the role of the premier. and then right down to the front lines, and then some autonomy around delivering to that role. Because I think if I look at what's happened, I think there's been lack of role clarity and leaders who have been trying to work with their both hands tied behind their backs, with no autonomy to do the things they know they need to do. So if we repeat that, let's come back in 10 years and we'll have exactly the same conversation.
I think that's an entirely fair point, Paula, and I would add to that that in that role clarity, at some point we have to get clear on what outcomes we're expecting those structures to deliver on. So if we're not holding them accountable to delivering on outcomes, which is clearly defined better health that looks like this, I'm going to say it looks like life expectancy as an example, then we can't expect the conversation to change. They'll do stuff, we just won't know if it's working. Peter?
So, again, it comes back to the structure piece. In our structure of government, the only center for your question around strategy is the Prime Minister and the premiers of each province and territory. That is it. Everything else is delegated from there. And again, I go back to the Estonian example. It was the president of Estonia who said, this is where we're going to go. It was President Kennedy who said we're going to put a man on the moon in 10 years, not because the bureaucrats thought it was a good idea. Everyone was telling him, oh, don't commit yourself. But it takes that kind of leadership. And so that is what we need. We need a premier to stand up and say, this is where we're going. And nobody wants to put themselves on a line in a system that has 4 years to deliver on that. It just doesn't win elections. Who's going to do that? Healthcare has a problem in this country being tied to government. Frankly, that's our problem that we don't want to talk about.
Yeah, so
That's the elephant in the room.
Well, so I might add on to that because I think there is some value in the tying on of healthcare to government to the extent that allows us to have a system that reaches with varying degrees of success and equity all citizens and is available for all citizens and not just those that
I'm not
have.
arguing for private health
Yeah,
care.
I get that. But what I think is more important in what you're saying, Peter, is, and I've had this conversation with colleagues, for example, in Australia, who do look at Canada like we're some weird bird. Because what they say to us is, why do you do things in that country 13 times over? And I go, we don't stop at 13. And we don't, right? So there is something about a strong federated approach to health service delivery and population health that we've never taken. In fact, population health is actually absent from the Canada Health Act as a protected set of provincial functions. So there is something that we've not done there that countries like Estonia and Australia and Bhutan and other places have done much better than we have.
So I think there's an opportunity, though. I think we can stitch together a digital health future for this country because it's a space that is vacant and is not currently seen by any leadership in this country. And I think that's the space that potentially ties us all together. Because citizens in New Brunswick and citizens in Nova Scotia, they travel, they want to be able to access their information, they want to be able to do the things and have the same kind of resources and feedback and data. They just assume that's going to be the case. Well, think of air traffic control. If every province and territory had its own air traffic control system, it'd be hard to get to Toronto. It's hard enough as it is. But it would be really hard to get to BC. You'd be going up and down. Well, that is healthcare in this country. But that space, there is an opportunity for leadership to make some changes in that. That does require a legislative foundation to enable. It's not the end, it's the beginning. But you have to have the vision to do that before it will occur. The status quo is not going to get us there. And to say that no deputy minister of health is going to be able to do that. I'm sorry. They're great people. They work hard. But they are not They do not have the ability to make the necessary changes. The only people that can are the Prime Minister and the Premiers. And they can make those changes. I think Canadians have to start demanding a little more than the status quo.
So the question then is, where does that leadership come from? And just speaking from a health care consumer citizen point of view, I would respectfully observe that the crisis in healthcare is a crisis in confidence, because people don't know who to believe anymore. And we kind of chase the headlines, we chase the shiny objects in terms of kind of priorities in the system, but at the end of the day, I think that citizenry have moved a tipping point from being frustrated to being afraid. I mean, people today are afraid that they won't have access to the services that they need when they need them, even though we know that the vast majority of times when people do need healthcare, it's there for them. So the experience doesn't bear out the anxiety, but people are afraid. And the politics of healthcare is poisonous, because politicians prey on that fear, and they make ridiculous promises when they're not in government. They break those promises when they get elected, because they knew they couldn't keep them really when they were on the campaign trail, but oh well, because it'll get votes. And it's obscene. And it is not it's not specific to any one political party. They're all equally guilty. In Nova Scotia, every mainstream political party has had a kick at the can. They've all done the same thing. So how do we change that dialogue? And how do we hit that reset? And how do we make it safe to have the candid, constructive, hopeful conversations about what the future of our healthcare system could be? Because Paula, you know, we started looking at this video, and I think everyone would say, yeah, that is pretty exciting stuff. But it feels like there is a big gap between that and now. Right. And I think we each have a part to play. Everyone in this room, everyone who's in any role of community leadership, everyone has a role to play in figuring out how to change the narrative, because we're not going down a good road now. And it's not a hopeful one. And I think truly the antidote to this is a measure of trust and a measure of hope. And I think that's what we're really, really hungry for. And I don't know where to find that today.
So can I answer that? And then Paula, sorry, but I think people are looking and finding that, frankly, in the private sector digital world. They're allowing Apple to have their personal data. They're allowing Facebook and Google to have their data without thinking about it, and we know that because they're getting results. They have tools that will actually help me keep healthy, help me monitor my health, and that is growing exponentially. That is not government, though. People are looking elsewhere for that trust.
Yes, I agree 100%. The example I was going to give you, you've both talked about the problems are long-standing and won't be solved in 4 years. The only example I've seen in Nova Scotia where the parties work together to say, we've got an issue that, again, we won't solve in 4 years, was One Nova Scotia and the Ray Ivany report. And I think it's fallen down a bit, but that was the best example that I had seen of all political parties saying, we've got to work together on this. So, I mean, if for economic development and exports, if we can do it there, why not for something as important to all of us as health?
Yeah, and I may be a Pollyanna. It's not something I've been called often, but I may be a Pollyanna. But I think, based on all of the people who I interact with in different roles in my life, I think that there would be an appetite today for that kind of political movement. Because I think the appetite at the moment is a very divisive one, the one that's kind of built on fear, and absolutely terrifying social media storm of misinformation that tends to drive opinion one way or the other. I think there is an appetite for a new kind of leadership, and I guess if there's any challenge I would put out there tonight, it might be that.
It was a strong call from the Avenue Report, and as a participant in the One Nova Scotia Coalition, you know, I had some sort of inside views on how those conversations went, and I think to varying degrees we did succeed in having that kind of unified leadership. I think it's coming up in Nova Scotia, but I think there are also places in Canada, I'm going to point to my home province of Prince Edward Island, where actually the call has been picked up and the leaders are behaving in a different way. So I also don't think it's Pollyanna. I think it's achievable with an incredible amount of hard work. But you know, that handshake between the opposition leader and the premier of Prince Edward Island sent ripples across the country, right? Oh my God, what are they doing? They're hugging! And the thing is, I was just at a conference in Prince Edward Island in August where the premier was present and talked about how the relationship has continued to grow and unfold. I think they were serious about it. So if that can happen in PEI, I have some hope that it could happen in other parts of the country. And if the burning platform was not the One Nova Scotia Coalition, surely $4.5 billion in the healthcare system is a burning platform for Nova Scotia today.
Yeah, this would be a burning platform.
Yeah.
Feet are hot. Feet are hot.
That's why the red shoes. Yeah.
Absolutely, and that's why maybe now would be a good time to throw it out to the audience to see if there is anything that you've heard that you fundamentally disagree with, anything that you would like to poke at, to talk about, to challenge, a new thought. Yes.
So I'll be the Hermes here. I assume Peter, you get that, and Jesse, a smattering of others. But so MJ, you point, I will follow.
I have never known such power.
What a great conversation. That was terrific. I really enjoyed the panel. And it ended exactly with the question that I wanted to ask, so I'm just going to pick right up on it. It was interesting that Ray Ivany deliberately didn't do a chapter on health, and the coalition seriously thought about doing it, not the coalition, sorry, the commission thought about doing it, but because of time constraints and the complexity of it, they didn't do it. And so it hasn't actually been done. And the thing that's interesting about the Ivany report and the coalition work, and even things like the field guide and the Atlantic Growth Strategy and other things that have come behind it, they've all not done health. But what they succeeded in doing was building a bit of a social consensus, a little bit around, you know, what problem are we solving for, and what are some of the things we need to be most attentive to, whether it's immigration, innovation, you know, et cetera, et cetera. That has not happened in health at all. And I think that what we probably need more than anything, you know, and Peter talked a lot about, you know, we need the sort of the premiers and so on, the political side to step up. But of course, politicians are responsive to what? To citizens, to voters. And if the citizens aren't there yet, the politicians are not going to be there yet. And so I think in order to get everybody there, there is a need to build a social consensus around the kind of problem that we're solving for and the kinds of things that we need to be attentive to in the solution. Naylor kind of did this a little bit recently federally. It got sort of buried by Harper. But I just kind of wonder if that's actually not what we should specifically be looking for, is the kind of Ivany of health as a way to build social consensus around the problem we're trying to solve for and the different kinds of sort of pillars that will be part of how we have to solve this as a province, as a way to get past, you know, Peter, what you've described as that sort of 4-year political cycle.
I completely agree with the notion that, you know, politicians respond to the people, and so we can't blame them. I'm not intending to blame them. I'm just saying where does that leadership lie? It's structurally, that's where it is. I think it would be great to have that Ivany kind of health conversation. I'd also caution us, though, that, you know, MJ's 25-year-old report has many good things in it that you could pull out and apply today. So we need action on top of that kind of engagement, but absolutely we need to be talking about this across the entire province, engaging people in the conversation, because it's not just about a doctor in every pod. You know, that's not going to get us where we need to go. So the answer is yes, but we need to really have an honest conversation of what we're going to do with that information after that. 3 parties coming together to do that would be a good start.
And some of the honesty in the conversation, I think, it gets to another level too. And I just had this conversation with the Faculty of Medicine at our annual retreat for the senior leadership there, because what I'm increasingly aware of is that the dialogue that we're having is around the system. And so we say the system is broken. It is not. I think we were talking about this before. It's not one system.
No.
So, and just to give you a sense as to what the complex. So this is where I have some sympathy for our politicians, because if you look at this thing, it's very difficult to sleep, I think, at night after you see it. If you are an Aboriginal, Indigenous, First Nations, Inuit, Métis person in this country, you operate in a different healthcare system than the non-Indigenous population. That's the starting point. If you are a federal prisoner, you are in a different system. If you are a member of the military, you are in a different system. That's just a start. We've got the IWK and NSHA in the province of Nova Scotia. We have different systems in every single province and different government departments involved in that system in every single province. You have at least 4 federal government offices that are involved in the discharge of public health functions alone, and it just goes on and on and on and on. So I think, for our political colleagues, there comes a point where you look at the healthcare system and the approaching 50% of the budget that it has, and you go, that thing is just a beast. So I think it's yes, we need some focus on it, and I think the starting point is the disentangling of where do you even start to rebuild something that has become that complex. And if any of you have read Thomas Homer Dixon, anybody in the room familiar with Thomas Homer Dixon, who's a professor? He was at Waterloo and he's now moved to UBC. And he has this book called The Ingenuity Gap, where he has gone around the world and described various systems of major influence, healthcare systems, economic systems, the World Bank, and he's interviewed the architects of these systems and asked them, how does it work? And they say things like, oh, we don't know anymore. I think our healthcare system has become a little bit like that. It's a runaway train. And so I think there's some latitude to be given our political colleagues who are looking at this thing, wondering how do you get into it. But it may, at this point, have surpassed our capacity to hold the ingenuity we need to get back into it and reorganize it. That wasn't very hopeful. Sorry.
Yeah, but honest. That's yeah. Yes, I'm pointing. It was my point.
Okay, it's your point.
Thank you. I'm a big believer that, and you may dispute this, that the least important department in terms of healthcare is the Department of Health and Wellness. That if the Department of Education, the Department of Community Services, you can go on and on, does not play their role in delivering a more healthy population, you won't get good outcomes.
Right.
So my question is, how can those departments better work horizontally, better collaborate with the Department of Health to achieve good health outcomes in the province?
I'm trying to Gaynor answer that, but I will point out that 25 or 30 years ago, when we had 50-cent federal dollars, a swing riding in Nova Scotia would get a hospital or a road. There are some communities that would have been better served if they got the road.
Yeah, no dispute here. So I think, certainly governments are trying, and across the country, governments are trying to be in that collaborative space. I think one of the ways that we can encourage that collaboration is clear focus on outcomes. So for example, when I look at the social determinants of health literature and I see the literature on education, what I become aware of is, and some of my public health colleagues in the room will have heard me say this many times over many years, the data on education is not that folks need a health-based education in order to succeed in life. The data on education is that they need an appropriately delivered and successful grade 12 diploma that focuses on math and literacy in the language of their choice. So if that's the goal, then I wonder how do government departments rally around, and we had this conversation at the One Nova Scotia Coalition, rally around grade 12 graduation as a outcome that we should be focusing on, and then focusing our policy attention and our fiscal attention to that as the outcome. I think in general, across the country, governments struggle to look at outcomes, and I think where we've seen successes in other countries is where they're doing exactly that. So by the same token, the successes that we saw when we were looking at this in Nova Scotia came, for example, from Scandinavian countries, and everybody goes, ooh, Scandinavia's got it right. But it's not because Scandinavia knows more than we do. When we looked at it, what we found was that they were actually measuring the crap out of everything so they could see the outcomes and course correct their policy if they needed to. That's something that I don't think we've invested in general in Canadian governments enough. And so I wonder if that wouldn't be the place for us to start to bring that broader collaboration around those broader sectors.
Do you want to add anything, Peter?
I don't think so for that, no. I mean, all of that is important. Meanwhile, the world is changing. You know, the video is right. It is becoming a very different universe. And healthcare is just the economic part of that we're talking about tonight. But the world is digitizing, whether we want it to be or not. We can go to Sheet Harbor and stay there and not ever have to leave in our lifetime. But the world is still changing.
What is it about Sheet Harbor?
I don't know.
I like Sheet Harbor.
It's just a nice name.
It is a nice name.
So it could be anywhere. It's not, the world is changing regardless. And so the government is slow to react, frankly, in most places. So there's nothing unique about us. What's unique to us is the politicization of our ability to change healthcare. And that and our inability to react quickly to change. We expect one change to change everything. And of course, it doesn't. These industries are failing frequently and often and are constantly changing. We're not allowed to make any mistakes. And in a system that allows no mistakes, takes no risks, and does not innovate and will not get there. The private sector, and I'm not arguing public-private, the private sector is making a whole lot of change very quickly. People are going to the private sector for their health care, and I think will continue to. The Netflix of healthcare is here for $9 a month. People will pay that $9 a month to have access to care if they can't get it in the public system. People are walking with their thumbs or whatever, their fingers. So that's what's happening today while we argue about how the Titanic, moving it, turning it, deck chairs. The world is changing so fast, people are making their decisions with their fingers.
So Peter, if I can add, you made a comment about structure. And of course, we saw the announcement of restructuring of the Nova Scotia Health Authority last week. And a lot of people would say, see, they didn't get it right. They're having to restructure. And I'm saying in Deloitte, do you know how many times we've restructured since 2015? And I mean because the world is changing radically. We've got new businesses, AI. We weren't in the AI business a decade ago. It's absolutely fundamental to who we are. So the health system, we'll still call it that in air quotes, needs to be restructuring every year. Things are changing. You need to fail. You tried that, didn't work. We try this. It doesn't mean it was a mistake. It doesn't mean we need to blow up the Nova Scotia Health Authority and we're going back to 4. No, it's just what progressive organizations do. Because my fear is, I love that we're talking about the future of health because I don't think anyone's talking about the future of health. We're talking about those 2 FTEs over there and how do we replace this hospital. You know, Mother Nature can tear it down and we rebuild it in a place that it shouldn't exist at all. So we need to talk about the future, paint a picture and say, how do we get from here to there? But what we did in the past won't get us there. So this conversation that you're suggesting, Matt, is exactly what we need to do. But we need to design for the future, not the past.
Peter, you'd mentioned a couple of times the 19th century approach to health professions and regulation. Now, that was an issue that somebody had indicated was something they would like to talk about. Can you maybe just elaborate on that?
Sure. Elliot Krauss has written about this in an excellent book called The Death of the Guilds. The health professions, as we know them, are the last vestiges of the medieval guilds. The gown, the graduation, the regulation, the workplace autonomy, and accreditation, which is really control over the state. So the professions were set up, and let's remember, and Paul Starr has written about this in the structure, social transformation of medicine more articulately than I can summarize tonight, but it wasn't that long ago that anybody could be a doctor, for example. In the 19th century until the 1880s, pretty much anybody could be a physician. Your training was anywhere from 2 weeks to 20 years, and it wasn't until 1910 when Flexner brought in the 4-year medical science university-based degree. 1910. That's the year my father was born. It's not that long ago. And since then, we have enabled all sorts of structures. But the point is that there was a lot of competition in the 19th century among all those people who were vying for care of the sick, the monetary remuneration of that. The physicians that we talk about today, there was all sorts of people who were very strongly in support of Christian Science, the belief that you look after your health yourself and health will follow. And there are lots of people who still firmly believe in that libertarian view. There's the chiropractic model and the chiropody kind of folks. They were all individual practicing. And medicine was successful in getting regulators in Canada and the United States to pass legislation to say that only a physician can be licensed to practice medicine. That's not that long ago in the history of our species here. And so in 1910, we decided it was 4 years to train a physician. And so the increased regulation of physicians allows physicians to control the market and who gets in and who gets to do what. And that then controls government around accreditation of who can be a specialist, et cetera. We've seen the rise and the success of the healthcare industry from 1910 to today, in large part because of that insular regulation. So let's not forget our history here. I think it's very important that we understand our history, because the solutions to the change lie in decoupling the history. Decoupling the history. Because the digitized world gives people the power to make decisions based on information. It's not that long ago, and I remember that we wrote Latin prescriptions. Why was that? So people couldn't understand what it was. Now, we don't do that anymore, but that's all about control. And now many professions are starting to see that the control is disappearing in the digital world. Democratization is changing that. When you have the power of information at your fingertips, you have a changing dynamic with your healthcare provider, no matter who that is. And so increasingly, as you have the ability to do things and look things up and have better information and resource, you're starting to look at your healthcare provider as a trusted advisor. Where should I get these options? What should I do about this? And that's a different relationship than the gatekeeper model that our system is built upon.
But I have a follow-up question for you, Peter, because I don't disagree, and I worry a little bit about the trend over the recent decades towards what I'm going to suggest is over specialization in particular within our profession as physicians. On the other hand, how do you balance that out against this new popular rise of anti-scientific sentiment, which also terrifies me? What? How?
Yeah, that is.
Was that articulate? I thought that was it.
That's the Facebook side effect. I think that is the reality today. That's why I think the future for healthcare providers, doctors and nurses and others, is to be your trusted advisor. So what do I do with this, doc? And that's like your financial advisor. You need to have somebody, because there's a lot of bad financial advice out there too. But you want to have somebody who you can trust and get through the Ponzi scams, so that you go to your provider and say, look, what do I make of this? What's the real, because what's beyond all this. That's why they go to school for so long, and that's why we should trust them.
So you're raising the issue of trust, I'm sorry, which I think is so vital to this conversation. And why do we trust a celebrity or a rogue health professional without any evidence when those with evidence aren't trusted?
Well, we shouldn't. I mean, I think the advantage is that we can look things up ourselves today. That wasn't always, not that long ago, the Latin prescription. You studied Latin and Greek, in school like I did. It's not that long ago. Today, of course, it's goofy. But that was because you had to understand the foundations in the history. And if you don't have somebody you can go to and talk to who you can trust, and whether it's a personal face-to-face or whether it's virtually, I don't think that really matters. But you need to have somebody who you can honestly get what's good for you back, and not because it's going to mean they're going to get some kind of economic benefit from that.
I have a question over here.
I don't want to take us back down the
I'm coming.
She's
I'm coming, Kara. Can we get some volume on this? So I just asked that you introduce yourself. First question from Matt Hebb at Dalhousie. Second question from Jason Contact at the Council of Atlantic Premiers. I just think you're also interesting, so it's important to tell us who you are.
Okay, so I currently work in housing, but before that I used to be the review officer for the Fair Registration Practices Act. And so government does have a lever that no one ever talks about. We do have a piece of fairness legislation that's supposed to oversee regulatory bodies to ensure that their registration practices are fair and transparent. So I just wanted to put a call out for the Fair Registration Practices Act in Nova Scotia. But I also wanted to say that the system of self-regulated bodies, government holds a pen on all the enabling legislation for those folks. So yes, we need self-regulated. I'm not advocating against self-regulation. I do think, though, that we need to consider whether or not self-regulating bodies are delivering on the policy goals of government. Government needs to figure out what those policy goals are, but then we need to see if the regulators are doing their jobs. And what I've seen in my experience is that government doesn't hold regulators to account, and regulators hold their own pens. They write their own enabling legislation. And I think that's really dangerous, and I don't think it's the way that we can move forward as a province. And yes, I agree about the 19th century bit. Thank you.
Anybody want to speak to that, or should we?
Well, I agree
I agree.
completely with what you're saying. And if the pendulum doesn't swing back to, patient safety, then I think these regulators.
Safety is like a crutch.
But they've moved away from that, and it's all about what's in the interest of members. So I'm agreeing with you, and I think the government does have the power, and I think that they're likely to use it unless we see a shift in that pendulum.
So let me just sort of add to what you said, and that is in the digital environment, there are many apps and resources, AI, that are currently making decisions that are unregulated, completely unregulated. And that space is growing literally exponentially. And so while we sort of fuss about the 19th century folks, the world is rapidly changing and all kinds of things are occurring. There are places around the world who are looking at the regulatory structures. The UK has, BC has just looked at its regulatory structure, primarily all around consolidation than anything else. But I think the digital space is like going so fast, and there's so many implications from that we're not able to keep up with the implications. And certainly I don't think governments are really sort of able to respond quickly with the kinds of changes. The private sector is, and the private sector is growing, I think. Now, I'm not a public-private person because I think that's a nonsense argument, but I just want to put that on the table, though. I think the private sector is where the action is in this space. Do they want regulation? I don't think so. Not particularly keen to do that. Worried about stifling innovation. So there's got to be I think there is a digital space across this country, like air traffic control, that needs to be articulated, that allows for innovation, at the same time protects the public.
Yeah, so MJ used the word modernization earlier. And I think that's good framing. So I have a lot of tolerance for complexity, but I have to admit that as soon as I get into a regulation, what's the right balance conversation around healthcare, I just get, I'm out. I don't know. I don't know what the answer to the question is. But I do think that there is some space that our governments could be stepping into around a call to modernizing our approach to service delivery and to the regulation of professions in a way that has us recognize the emerging complexity of the situations that we're now in. What's funny about it to me is I was at a meeting of actually senior public health people with the Canadian Institutes for Health Research about 5 years ago. And there were about 3 of us in a corner who got into this space and realized the Canada Health Act was outdated and kind of went, if we want to go here, we need to modernize the Canada Health Act. And then there was this, oh my God, why did they say that out loud? We might have to do something about it kind of thing. There is real paralysis around some of these institutionalized approaches that we've taken that would take some of the courage and leadership that we talked about from government structures, federal government in particular, in order to move us from.
Do you want to maybe, can we double or triple it up? A couple of questions at a time?
Sure.
Okay. First question, hands up for second question. I'll still follow your points.
Okay.
So I introduced myself as Manoj Vora. I'm a family doc. I'm now the chief medical officer for WCB. I got to be the president of the medical union as well as be a VP with Peter. So I think I've seen all 4 faces of healthcare over the last 35 years. So the first, I appreciate all the conversations. I don't think 2040 is realistic. I think that there's way too many partners in healthcare and the way we deliver it. We have rural Nova Scotians I work with every day, and all they want to do is see a doctor. They don't want any technology. I see people who are the same age wanting technology every day. The question I ask you is, will we have doctors in 2040? What is the value of a doctor in 2040 compared to now? And the reality is, with AI, as we've talked about, how does that affect all of our outside world, the medical schools, the people, all the caretakers? I'd love your opinion on that.
So I'm sure we do all have a view on that. And again, Deloitte's done a lot of interesting research on the future of work, and the way all of us work in the next 10 to 20 years will change dramatically. And we talk about it as being first influenced by what can be automated. And I'm not talking about jobs that can be automated. People, to go to that extreme, tasks can be automated. So those repetitive tasks that don't require judgment. So that's going to happen first, and that's just a given. That stuff will not be done by human beings in the not too distant future. Who does the work? Part-timers, the gig economy, people moving from organization to organization. That's a given. I think people who come into an organization, stay there for 30 years, retire from there, a thing of the past. And then where work gets done. Virtual care is changing everything. What will be able to be done at home, to in-home diagnosis of things that today you have to go to either your GP or Emerge or wherever to have done. So I think there will be dramatic changes, and it is those complex cases that require judgment and that advisory work that Peter described that I'm having a hard time imagining a world where there isn't a need for that. But it's not what they're doing today.
So it's a great question. I struggle with, in Canada, we produce 3 times more physicians than the rate of population growth. And yet we have a shortage of physicians. So I think there's something fundamentally problematic in how we structure. And it comes back to the non-system. If we're continuing to produce physicians, as we continue to, for the 19th century model of independent, free-range chicken world. I've often talked about physicians being pushcart vendors, and I'm one. I'm a recovering physician. But we can do whatever we want and go wherever we want to go. We don't have to partner or team up with people. I can be a solo practitioner, or I can work with a group. And if we're training people with that old sort of hang your shingle 30 years and die model, then we are flying in the face of the modernization that's occurring around us. So I think that we probably need to have and empower and enable, and we do have the ability to have more healthcare providers doing more of what their competencies are. We used to talk about, span of control and what you're, able to do. So, I was part of looking at the health profession legislation in Ontario around the SARS crisis, post-SARS. And when we looked at what some 33 odd professions, the overlap was amazing. So many of these professions can do exactly the same things. And I'm talking about basic emergency types of things. I'm not talking about neurosurgery or, even gallbladder surgery, any of those kinds of things. I'm talking about just basic sort of emergent sort of tasks. And yet overlapping in a regulatory structure. So, we could have people operating to their full scope and have a lot more access to answer your question than to rely on a gatekeeper as an access. And doctors work very hard, and don't misunderstand what I'm saying, but they should not be the gatekeeper to the system. They should be used to their maximum skill, and it's highly skilled. And so there should be others who people have access to. Under our current model, you have to go see a family doctor to access everything else. Whereas you might, be better off to see a social worker or a nurse practitioner or a physician assistant or paramedic or whatever. We have a little bit of, that, like a tiny little bit. But the 99% of the iceberg is dependent on going to see a family doctor to get access to everything else. Digitization actually turns that up on its head. And citizens can have access to any of those services if they're allowed to. And we're the only ones who are keeping them from access to that. That's not going to make some people happy who are currently like the gatekeeper model. The status quo is very attractive, and it works for those people. But in order to solve the problem you're talking about, we have to break that down and have maximum access to the services that you need. And yes, there's going to be a role for family doctors and physicians in the future. Absolutely. It just will be different and probably better and make them happier too, because folks aren't pretty happy. They're not very happy across the country. And there's lots of data around that. Folks are unhappy with their current roles. And I don't think having more of them is going to make them happier.
Peter,
Practicing to full scope is a good segue, because we have actually talked to full time. It's 6:30, and So and just in the promise, because I expect that there are people that now need to move on to other parts of their real lives, I will suggest that this might be, since we've used the word happy and better, finally, this might be a good time to wrap up. Thank you for coming. Thank you for sharing. This was a pleasure. This was a lot more fun than I was expecting. Thank you, everybody.
All right, I'll take some juice here, Martin. So thanks everybody for coming. Really appreciate you taking a couple hours out of your evening to join us. I think this was an incredible panel discussion. I consider it my fundamental number one hobby to attend panel discussions, and this was the best I've attended in a very, very long time. So thank you, MJ, for moderating a great discussion, Peter, for sharing your insights and sharing all the knowledge you've accumulated in your many roles.
Just trying to say I'm old.
Paula, as always, and Dr. Gaynor Watson-Creed, really appreciate your time. And all of you for joining us. I know I'm just looking around the room, there's an incredible amount of knowledge and healthcare professionals and leaders and people who've been operating this machine and doing their best and thinking about this and dreaming about this. And so appreciate you giving us your time and coming out for a discussion like this. So it's important for us, it's important for the province to have conversations like this and to keep the conversation moving and to continually think about what it can be and not just about what it is and kind of minor improvements, but what are we really trying to do, and what are the key kind of, what are we really trying to, who are we really trying to serve? So so thank you very much. And I'll just reiterate by saying this is number 2 of our series. There's lots more to come. Our next talk is on January 8th. We have an almost equally impressive speaker, Mr. Michael Wernick. He was the clerk of the federal government up until April of 2019. And he's going to be sitting down and sharing his thoughts on SNC-Lavalin, but also the future of the federal government, Blueprint 2020, but also the changing pace of government and just how difficult it is to manage a country of our size. So thank you very much. Hope to see you there. He's going to be interviewed by a person we love, Don Connolly, who's coming out of retirement just to have this conversation. So again, thank you very much. Hope to see you again soon. We'll send a little survey tomorrow morning. We'll say, did you enjoy your evening? And again, thank you very much.
And if I can have the last word, be kind to each other, because nobody can do this alone. Be kind to each other.